within the hour, but if you want to go back and look for the information, we'll have that available for everybody on our website. Also, if you have a question, we will have Q&A at the end. You are welcome to enter questions at any time through the chat feature. If you are online, we'll also open up for folks who are on the phone to ask questions at the end. And if we don't get to everybody's questions, you are welcome to email your question to info@nvhr.org, and we will do our best to get those questions answered and sent to you. So today's webinar is part of NVHR's program on hepatitis C baby boomer screening and linkage to care, and Tina Broder, our program manager, will talk about that program later in the webinar. The purpose is to provide information and tools on why and how to make the case for the importance and urgency of screening those born from 1945 through 1965 for hepatitis C, and to share information about NVHR's educational program and resources. So I'm going to turn it over now to Dr. Cami Graham, who probably needs no introduction to many of you, but she is the co-director of the Viral Hepatitis Center, Division of Infectious Diseases at Beth Israel Deaconess Medical Center in Boston, a great partner to NVHR, and a leading hepatitis C medical expert in the country. So I will turn it over to Cami.
Okay, Ryan, thanks a lot. So the goal of this section of the webinar is to really demonstrate how to provide a compelling argument to your audience about the need for hepatitis C testing with a real focus on baby boomers. And so I'm going to go over data probably many of you are very familiar with, but just demonstrate how I talk about it, whether I'm talking to primary care providers, advocates, policy, government officials, public health officials, or any other audience. And, Tina, do I have the control, or do you?
I do. We're on slide 2 right now, your page.
Oh, am I on the, so I'm just seeing the title slide.
Okay. So now I'm on identifying patients with hepatitis C.
Okay, great. I'm seeing that too. Sorry. Okay, so one thing I try to really make clear is that we actually don't really know how many people have hepatitis C in the U.S. When you look at that 3.2 million point estimate that's derived from NHANES, which is a national survey that was designed to look at the general health of the U.S. population, it was actually focused on people who are stably housed. And so when you look at a disease like hepatitis C, which can disproportionately affect people who are institutionalized, who are homeless, who are incarcerated. Actually, the active military was excluded from NHANES. You're going to substantially increase those estimates. And if you look at the regions of the U.S. that were specifically surveyed, they often don't include our large urban coastal cities, which have dynamic and complicated international populations, many of whom have immigrated from countries that have higher prevalence of hepatitis C. So most people actually kind of agree that we're more in the 4 to 5 million people who have hepatitis C than something closer to 3 million. Most of these people were infected in the 1960s through the 1980s. And that's because we had a lot of mechanisms of transmission at that time that became less common in the late 80s through the 1990s as we started implementing universal precautions for HIV. And through our HIV universal precautions programs, we ended up also decreasing hepatitis C prevalence. And you can see that because the prevalence of hepatitis C started dropping before we even had diagnostic commercial tests for hepatitis C. In the 1980s, it was up to 250,000 cases per year that were transmitted. About 50% was via drug use. But the rest of the transmission was from blood transfusions, sexual transmission, things like tattoos. Before we started having universal safety precautions for things like tattoos, medical procedures were probably a substantial cause of transmission of hepatitis C, and then other community factors that we really don't understand well. It's estimated that up to 75% of people have not been diagnosed, and it's very clear at this point that risk-based screening misses many people. First of all, you've got a lot of stigma associated with injection drug use, even if it was decades ago. And then many of these other risk factors for transmission are either poorly understood or the person being queried actually doesn't have any idea if they had an exposure. Okay, next slide. So usually when we talk about the sort of the funnel of patients and how to get them from diagnosis to treatment, we focus on the part of the funnel that starts with the red arrow there, improve the diagnosis. But what you really need to focus on is the pool of people who need to be tested in order to find the 4 to 5 million people who actually have infection. And it's estimated that about 50 million people have risk factors that have been identified as requiring testing for hepatitis C. And there's probably about 80 million people in the 1945 to 1965 cohort who would fall under baby boomer testing. And many of that 50 million actually fall into the 80 million cohort. And so when we think about what it's going to take to test tens of millions of people in order to identify a pool of people with hepatitis C, then it becomes clear that complicated, labor-intensive, expensive interventions aren't going to work. Okay, next slide. So when I show this list of who should be tested for hepatitis C to primary care doctors, I almost universally get laughter because this is a lot of factors to ask people, and many of them, like receiving an unregulated tattoo, whether people have had an occupational exposure, surgery before implementation of universal precautions, people aren't really clear whether or not this is something they might have been exposed to. Even something like blood transfusion, I'll often hear, I woke up in the hospital, I have no idea what happened. I don't know if I got a transfusion. So something that I think people think should be something someone could remember. And so, and frankly, if you've got a 15-minute time slot to take care of a patient in a busy primary care practice, you're not going to go through all of these risk factors. And so the fact that the CDC and the U.S. Preventive Service Task Force lined up on the recommendation for the 1945 to 1965 birth cohort was one of the more significant recent points of progress in dealing with the epidemic of hepatitis C. Next slide. So you can ask, well, what if you were to just look for people who we think have more of a risk of having significant infection with hepatitis C. So I'll often have people say, well, I check everybody whose liver enzymes are elevated because those are the people who, I think really should be tested. And these folks will be convinced that most people with elevated liver enzymes, they actually are testing. So one problem with this strategy is that there's a pretty good chunk of folks who have normal liver enzymes. and you're not going to find them if what you're looking for is abnormal liver enzymes. But this is sort of looking at the opposite question, which is if someone has normal liver enzymes, how well are they actually being tested? And it's a check cohort that's put together by the CDC, and they looked at 865,000 people just in general practice in a multitude of health systems. And they looked at the people who had at least 2 elevated liver enzymes and asked how many of those had been tested. And it was only 43.9%. Of that group of people, the prevalence of hepatitis C was 8.2%, which is a pretty strikingly high. That's 1 out of 12 people. So this was a very enriched group, but clearly less than half of people, even who had abnormal liver enzymes, are being tested for hepatitis C. And this is just to show we are doing a terrible job testing people for hepatitis C. Next slide. So, it was when the CDC recognized that one way to grab a chunk of people who have a higher prevalence of hepatitis C than the overall population was this very fixed cohort of people who were born in the 1940s, actually through the early 1970s. And these are those people who, because of their age and because of what was leading to transmission of hepatitis C, were getting exposed in the 1960s through the late 1980s when we had such a high rate of infection of hepatitis C in this country. So this is a fixed cohort. 10 years ago, the median age was about 48. Right now, the median age of this group is about 58. And in 10 years, the median age is going to be about 68. As you all know, we have a second epidemic in our youth, and that's driven mostly by prescription drug use and injection of that, or progression to heroin. It's a little bit unclear how large that group is. It's somewhere in the 20 to 40,000 range, probably could be a little bit higher. But I don't want, that's a really, really important group of people. But we're focusing on this group because it represents about 75% of who has hepatitis C in this country. And because they've been infected for so long, they are the ones that are at most increased risk right now of having substantial liver disease. It's estimated 35 to 40% of these patients already have advanced fibrosis, that's bridging fibrosis or cirrhosis of the liver. And so they have both the highest prevalence and they have the highest risk of severe disease and the most urgent need to be diagnosed now. Next slide. Now, I mentioned already that the NHANES survey probably dramatically underestimates the number of people with hepatitis C. So I want to show you an example that we use here in Massachusetts, where if you looked at NHANES and the prevalence of hepatitis C in the adult population in Massachusetts, which is about 5.8 million, we should have about 80,000 people with hepatitis C. However, the Department of Public Health has reported to them, so both diagnosed and reported, 110,000 people. Now, about 10,000 of those people have unfortunately died. So we should have about 100,000 people diagnosed, reported, who are still alive. And if you even estimate that Massachusetts has a 50% diagnosis rate, so it's not 25%, it's 50%, that means we probably have about 200,000 cases of hepatitis C in this state, which is obviously far higher than the 80,000 that NHANES would estimate. And I suspect that most states would have the same phenomenon if you look at it this way. Next slide. And this particular study was the one that actually drove us here at Beth Israel Deaconess to decide to start more aggressively screening our baby boomer population for hepatitis C. We had recognized anecdotally that somewhere around 20% of the patients that were presenting to our transplant program, our liver transplant program, for decompensated liver disease or liver cancer, were getting their hepatitis C diagnosis at the time of presentation to transplant. And we were like, what's happening? Why are we having these late diagnoses? Well, around that time, the Department of Public Health here in Massachusetts took those people who they knew had been reported as having hepatitis C and then looked at those people who had died based on death certificates and asked how many years before someone died were they diagnosed with hepatitis C. And you can see the median time from diagnosis to death was 3 years. Now, the median time people usually, we've got a lot of background noise here. The median time people usually survive from first episode of liver failure is about 5 years. And so this means that people are presenting with liver failure or liver cancer, and that's when they're getting their hepatitis C diagnosis. And obviously, that's too late for many of our interventions. And the other striking thing was in a state that, has pretty good access to health care, the median age of death was 53 years. So these people are dying young. And the CDC has recently done a study looking at the years of life lost in people with hepatitis C, and they estimate it's about 15 years of life lost if you have hepatitis C. Next slide. So I just wanted to show you those couple of slides to emphasize why it's really important when you are going out and advocating for a group of people in your state to care about hepatitis C and to do something about it, whatever it is you want that audience to care about, to have state-specific data to show them. Because otherwise, I think there's a tendency for people to say that's somebody else's problem. And I know when I started first going around and saying, this is us, this is Massachusetts, this is the people we are responsible for, it changed the course of the conversation. So when you're educating primary care doctors, you personalize the importance of hepatitis C as a disease they are going to see in their practice, in their patient panels, and that it's their responsibility to find these people before they show up needing a liver transplant. It also increases their interest in being part of the implementation of hepatitis C screening programs in their health system. And then it's really important for policymakers, whether you're arguing for increased funding or additional resources for your local and state departments of public health, or perhaps advocating for legislation, when you can demonstrate this is our problem in our state, it makes the argument much more compelling. And then, of course, community awareness and advocacy. Next slide. Each one of us has a state viral hepatitis coordinator whose job it is to spearhead our state-level epidemiological research. And I will tell you, these folks have no resources. They are given basically their salary and almost nothing else. And so unless they are working with departments of public health that can scrape together, bits of resources from here and there to help support some of their work, or they are really good bakers and can, put on good bake sales, they have no money to work with. And so a lot of states, don't have as much epidemiological data as they need, and I think that's one reason why all of us that care about hepatitis C should get out and try to figure out how to mobilize additional resources so people can gather the data that help us understand what the problem is so we can understand how to best help people. NASDAD, which works closely with the hepatitis coordinators, is working with us to help try to gather up state-by-state level data. And our goal, we've already gotten some information from the viral hepatitis coordinators, but our goal is to have, as part of the NVHR website, a state-by-state level drop-down of slides that depict either basic epidemiology or things like time to death or other important data that might help you make an argument in your state about why hepatitis C is important. And we can send updates as we get that on board. And hopefully what we'll be able to offer you all is state-level slides that you can plug into core slide decks, such as the ones we have on NVHR, to customize a local presentation. Okay, next slide. So I'm just going to tell you a little bit about our experience at Beth Israel Deaconess, and then Tina is going to talk more broadly about some of the program aspects that we're trying to do on a more national level to help as many people as are interested. So Beth Israel Deaconess is actually within a larger group called CARE Group, which is a network of academic hospitals, primary care practices, community health centers that share a common electronic medical record. It's about 5,500 clinicians and somewhere around 1.5 million patients. So as I was thinking about how to implement a baby boomer testing program, I realized that some of the pilot models I had looked at, which required a lot of hands-on education of clinicians, wasn't going to work in a complicated system that's spread out all over eastern Massachusetts with over 5,000 clinicians. And so how do we make this very streamlined? So we did implement a prompting EMR, and I'm going to talk about some of the complementary work that went in with that. To prompt testing for a hepatitis C antibody in everyone born 1945 to 1965 who had no prior record of testing in our system. And I do want to emphasize ongoing risk-based testing was continued, and I'll show you data to support that. This particular program went live on June 4th, and in the first 10 months, we've tested a total of a little over 20,000 people for hepatitis C. Next slide. And so, one thing that that we had to do initially was overcome a lot of barriers. I think these barriers are a little bit less now that the U.S. Preventive Services Task Force has provided support with that grade B recommendation, and as we've had more sort of media exposure about testing, but it's worth formulating some answers to these very common concerns that primary care doctors will often have about testing. It's 80 million people, and I think there's an immediate kind of reaction. This is too expensive to test all of these people. And how I respond to that is, we have a recommendation in women born who are aged 40 to 50 right now that they either get a mammogram every year, every other year, or every no year. And we don't actually know, and that's about 20 million women who we're still trying to figure out about mammograms. And mammograms are in the $150, $160 range. A hepatitis C antibody test is $10 to $20, and you do it once for the baby boomers that are not being identified through risk-based testing. So in the whole scheme of the kinds of things that we test for, this is well within the realm of what we already do. There are clinicians who believe you can tell who actually needs to be tested for hepatitis C, and there's no point finding somebody before they have clinically significant disease, and that's just a matter of educating people. By the time that person has recognizable significant liver disease, it's often too late to do anything about it. They're often in very late stages, and now you're referring them to the transplant program. It's silent until the very end. There are folks who still believe that you're going to die with your hepatitis C, not of it, and data such as the Massachusetts one that you're really losing about 15 years of life expectancy help with that. There are clinicians who don't realize that hepatitis C is curable, and that's just a really important thing to get across. There are people who think that the antibody test itself indicates active infection, and they maybe don't fully understand the role of a follow-up viral load test. And then the last one is probably the most common. We have too many prompts. We get burned out. We can't stand the thought of one more prompt. And again, when you say, this is a click on your lab slip, when you're already checking the cholesterol panel, it's just one additional test. When you do that test, the prompt goes away. That ends up quickly dissipating that concern. Next slide. So here are the steps that we use to implement baby boomer testing. I'm actually not going to go through the whole thing in the interest of time. These slides will be available. But you do need to create a core team. And we had primary care, infectious disease, hepatology, the database folks, and clinical pathology. And we had educational tools that we made available via email blast. We actually were able to link them to our electronic prompt. I'm not sure all EMR systems have that ability. And we ran around and gave talks to different primary care groups when they were interested. But it was having materials that complemented the prompt so people understood the rationale for the testing and knew next steps they were supposed to take once they did the testing. And that helped a lot with the acceptance. And many of these educational materials, as Tina's going to describe, are on the NVHR website. Next slide. And again, this is one example of a one-page educational sheet that was vetted with a number of focus groups in the primary care departments here. And so this isn't everything. This is what they wanted to see. And so again, that resource is on NVHR, and it's a document that you can modify. So if you've got additional information your providers want to care about, you can add that on. Next slide. And the other thing that I think surprised me a little bit once we first started this program was people would say, I've already tested 50 people and I haven't gotten any positive. I don't think this is working. And I had to go back and say, 1 out of 30 baby boomers means you're going to test 330 people to find 10 antibody positive people, and 7 of them are going to be RNA positive. And so just setting expectations of what they are going to expect, that they shouldn't be testing 50 people and finding 50 people who are positive. That we wouldn't actually be surprised if it was a lower number. And I think I have examples. Can you go to the next slide? Oh, I don't. Can you go back to one slide? And so we've actually, looked at the data to be able to show people that this is working. We found about 500 people so far that are positive. That's a 2.4% prevalence rate, and that's because we already were doing quite a bit of risk-based testing before then, and we are testing a lot more women than men, but 2/3 of the people who are positive are men. And I think anybody you ask is going to say more women than men go regularly to primary care, so it's not surprising that we've been testing more women. The prevalence in women is less than 1.5%, and it's about 3.5% in men. So in our next iteration of this, we're trying to figure out how to identify and capture more men in this program. Okay, next slide. This is the CDC study that demonstrated that a baby boomer testing program like this is as cost-effective as screening for cervical cancer or screening for cholesterol, which are readily accepted primary care screening interventions in the United States. And this actually uses the cost of a protease inhibitor, interferon and ribavirin, and our current DAAs are not actually that much different than the cost they use for this particular analysis. Next slide. So this is showing now, I want to show first the green line which is the non-baby boomers. So these are the people who are being tested based on risk-based testing. And you can see that has not changed. We were a little bit worried initially that as we started emphasizing boomer testing, that people would stop doing the risk-based testing, but the data don't support that. And go to the next slide. And this actually now pulls out the baby boomers. You can see when the CDC guidelines came out, and we had a lot of media attention here, and we were running around and giving talks and everything, and you could see a little bit of an increase in testing. Education alone does work a little bit, but it's really, it's nothing compared to the combination of education and an electronic medical record prompt. We did have a dip, as you can see, around the Thanksgiving, Hanukkah, Christmas, New Year's time period, but it seems to have come back up since the holidays. Next slide. Oh, here's the slide that shows that we're testing a lot of women, but it's the men that have the disease. And that's in the boomer population. In the non-boomers, it's maybe a little bit more equal. And we're still trying to figure out how to address that. And you know, part of the NVHR program is quarterly calls where we try to brainstorm different ways of approaching things. People have different best practice patterns, and I'm constantly looking for suggestions of how to improve this program as well. Okay, next slide. So next, you need to make sure your audience understands why they need to really care about hepatitis C. Go ahead. I think all of you know this, but this is a slide that can be available as a resource just to make sure people understand this is a very serious disease. Next slide. And that the number of people with decompensated liver disease with liver failure is going to peak in 2020. So we have basically 5 years to get our act together. And that's how I put it. I'm like, we don't have 15, 20 years to figure this out. And we don't have the luxury of spreading treatment and cost and all of that stuff out over 20 years. The more people we can treat now, the fewer people are going to end up with decompensation. And the more we fiddle around, the more people will die unnecessarily. Next slide. And this slide here is probably the most compelling slide I've used, especially in the advocacy and sort of policy realm, to emphasize we have more people dying now of hepatitis C than HIV, and the numbers may be substantially higher than what we see from death certificates because the CDC has demonstrated substantial underreporting when you look at death certificates for hepatitis C. And so this is, I would say, a mandatory slide to include in any advocate talk. Next slide. And then very simply, people have to walk away knowing the best way to reduce the likelihood that someone will develop severe complications of hepatitis C is to cure the infection. And I didn't say, and it's only the, you know, F3, F4s, and it's only the people who haven't used substances in 6 months. This is the best way to change the natural history of the disease is to cure them. Next slide. And this slide just really shows you dramatically decrease the risk of liver failure even in people who were treated who already had advanced fibrosis. You decrease the risk of liver cancer by about 80%, not 0. So if you wait until people are F3, F4 before you treat them, you subjected them to lifelong ongoing risk of liver cancer. Now, if somebody's already F3, F4, there's nothing you can do about that. They have an urgency to treat. You need to treat them right now. But if someone's F2, why would you wait until you now have to screen them the rest of their life for liver cancer, which is expensive, it's anxiety-producing, and it's unnecessary. Next slide. And then, you know, I think people have, this perception, these medications are incredibly expensive, and we don't even know if they're worth it. And, this is part of changing that dialogue, is saying, cures dramatically reduce the risk that bad things are going to happen to people and that they're going to die unnecessarily of a curable infection and young. And these are the cure rates we're getting. So this is an example in genotype 2 patients where we have cure rates of over 90% even in cirrhotic patients. Next slide. And here's genotype 1 patients. It includes cirrhotic and non-cirrhotic patients, again, over 90%. Next slide. And here's another example in genotype 1 patients, including cirrhotic patients, over 90% cure rate. And so even in our most difficult to treat patients who back in the PEG interferon ribavirin days, we might have been looking at a 15, 20% cure rate, we're now looking at reliable cure rates of greater than 90%. Yeah. Okay, next slide. Okay, so that was my part, Tina.
All right, thank you, Cami. So now I'm going to breeze through a little bit of the program resources we offer through NVHR's website to help you implement screening in your community or health system. So our website is broken into sort of 3 main sections, which are resources for provider education and training, patient education and resources, and then highlighting the work of our community partners. So first, in the category of provider training, we have a variety of handouts and fact sheets. One of them that we recently released was a fact sheet on the value of screening despite an uncertain treatment climate. Obviously, the cost of drugs as well as restrictions to the new medications are getting a lot of press and are creating resistance on the part of providers and patients to get screened. But we want to continue to emphasize the message that it's essential to have a universal screening program for baby boomers in order to find these very ill patients who really don't have the time to wait a few years to get screened, as well as the fact that patients have a right to know their status and that treatment can begin at diagnosis. We also have a variety of handouts and fact sheets for primary care, such as the one-page handout that Cami highlighted outlining the testing protocol, as well as some examples with educational materials from the VA and the CDC. We have some examples of implementation support for a birth cohort prompt and electronic medical record, and I'll talk about that a little bit more in a minute. We have a variety of resources for continuing medical education, and as well as handouts on the specific coding and billing details. We have one highlighting a flyer from Hep-Free Hawaii that encourages patients to actually bring it directly to their doctor, and it gives the CPT and ICD-9 and 10 codes to bill for hepatitis C screening. We also highlight some links to provider training modules from the University of Washington and the University of Alabama at Birmingham, and we have links to treatment guidelines from AASLD, IDSA, and the CDC. Now I'm going to go through a few examples of prompt implementation support on several different EMR platforms. This is an example from the Centricity platform shared with us by Maggie Beiser at Boston's Healthcare for the Homeless. And this is an example of screening for fibrosis that they use within their system. So I'm not going to go way into depth on this, but just so you can see what it looks like in a few different systems. This is the See a Difference program, which is using the Allscripts prompt. This was shared with us by Stacy Truskin at Drexel University and also through Hep C Allies of Philadelphia. And you can see that they have a prompt for all patients in the birth cohort who haven't been screened for Hep C. And then it's very simply spelled out here that you type in HCV screen in order to order the antibody test. And for those who have a reactive test or an ICD-9 code consistent with chronic infection, it then goes to an alert to order follow-up testing. And it's pretty simple and straightforward. They just rolled this out this summer, and we're hoping to get some updates to hear how that's going for them. We also have an example shared with us by Lynn Taylor at Miriam Hospital as part of the Lifespan Network. She's also the project director of Rhode Island Defeats Hep C, and she shared the prompt that she implemented into primary care using Epic system, and this uses a best practice alert for those in the birth cohort who need testing. And as you can see, it just pops up one time that they need a screening for Hep C because they're in the birth cohort. And I'll mention at this point that you can see that really to get these birth cohort prompts implemented, it really takes having a champion in the healthcare system to get it done. The next section we have on our website is patient education, and this is fairly straightforward. We have a variety of links to educational handouts, testing resources, and also some event templates that some of our community partners have shared with us that they use to advertise their events. We also have links to patient support resources and patient assistance programs. The next part of our program is working with our community partners because there are many of you who've been out in the field doing this work for a long time, and our hope is to really just gather up the best practices and provide a forum to share and collaborate. So we do that through quarterly working group calls and also having a network of providers and community advocates who can speak with each other and share information. And through our program, we have a monthly call with the CDC, so we have an ongoing feedback loop with them to share what's happening out in the field in the community, what we're hearing, and also to hear from them what resources are coming down to be distributed. I'd like to acknowledge our community partners who generously shared their experiences and resources and allowed us to highlight it on our website. And to share with you briefly some of our upcoming plans for the next year or two. We're planning several conference calls and webinars. One that will probably happen around November is there'll be a new launch of the CDC's No More Hepatitis campaign materials. So we'll hold a webinar when that comes out. We're also hoping to do a webinar or call highlighting different patient support resources. We're going to do something to highlight groups who are doing joint viral hepatitis work of Hep B and Hep C. Hep Free Hawaii is an organization that comes to mind that does an excellent job of working in both areas. We're also providing additional support for EMR platform users. We're in the process of scheduling a couple of webinars for people who have Epic systems that want to implement birth cohort prompts, and we hope to do future collaborations with other EMR platforms. We're going to host a webinar or call around working with the media. And as Cami mentioned, we're going to continue to provide information around using state-level data to advocate for screening and linkage to care programs in your community. And we encourage your feedback and sharing any examples you have from your successful programs that we could highlight and add to our website. So at this point, I'm going to try to take people off of mute and open it up for questions and discussion. And I'll turn it back over to Ryan to moderate.
Thanks, Tina. Thanks to Cami and Tina for the great presentations. We're now unmuting the lines to take questions over the phone or over speaker, and we're also small technology issues and waiting to get those questions that have come through on chat. But the lines are now unmuted, so if anybody has a question to ask over the phone or speaker, please do so. Any questions for Cami or for Tina? Okay, and we may need to go back on mute. So Tina, are there any questions that have come through through the chat?
Okay, sorry. I put everyone back on mute for the moment. And if you're logged in, you might be able to unmute yourself. And in the meantime, I'm going to try to check for questions, and I'll read those out. So one question we had, will copies of the slide be available? Yes. Another is, what are the best approaches for EMR implementation, and who should be at the table in a system? And so I'll let Cami answer that while I try to work on the muting function.
I think Cami has been muted.
Yeah, I'm going to unmute her first. Okay. All right, Cami, you should be unmuted. Could you go ahead and answer the question? Who do you think should be at the table to make a change in the EMR system?
Yeah, so you really want a variety of stakeholders at the table. There has to be one or more hepatitis C champions, and that person really needs to be from the inside of the system. People, community advocates can play a role, can identify that person and give them support and encouragement, but each health system is very different, and so you've got to have somebody, and then and that person internally is going to get that internal buy-in. That person could be a primary care doctor, they could be an infectious disease doctor, they could be a GI or hepatology doctor. Typically, it's going to be one of those groups of people who is willing to, go out and argue the case, because every single person's EMR system is overloaded with requests. We've got a lot of government mandates. They're called meaningful use criteria that we're all quite burdened down with, and there's always quality kinds of measures. So you have to fight your way into the queue. And what we're hoping through the NVHR support is to give people the support tools to be able to say to their IT people, listen, somebody's already worked out exactly how to do this prompt. This is very straightforward. This is not going to take long. I want to say the EPIC folks say that within their system, somebody who knows how to do EPIC program, it should take 2 hours. Not 2 weeks, not 2 months, not 2 years, 2 hours. And so once you find that champion, they gather up some key folks like in primary care, some of the providers, the hepatitis C providers, and then they need to approach usually a decision group that vets different proposals for introduction to the EMR, and then the IT people that are involved with it. And so there are a few steps that are involved, which is why we're trying to create this support group to help kind of, demonstrate to people what needs to be done so they don't get kind of overwhelmed. But those are my initial thoughts.
And another question is, beyond prompts in EMRs, what are some suggestions for how to accelerate uptake of the Uspstf recommendations?
Yeah, you'll notice we started with the baby boomer prompt because it was very easy to pull out year of birth from the system. Every single medical record has year of birth on it. We've done a very poor job identifying things like prior blood transfusion or history of injection drug use or various other risk factors within the system. And the CDC has actually done big chart reviews, and nobody does a good job. So it's hard to figure out how to do prompts based on things that are not well captured in the medical record. And then we also found that so many people had elevated liver enzymes that it would overwhelm the system if we tried to use that as a prompt. So what I reassure myself is that if we do really good baby boomer testing through prompts, we'll capture 75% of the people. And these folks, some of them might currently be injection drug users, might have been past injection drug users, might have gotten a blood transfusion, might be from immigration from a country with a higher prevalence. It doesn't matter because basically baby boomer testing is a cylinder you put on the entire U.S. population. And over the next couple of years, we're going to be working on how to capture, especially the at-risk groups. We may put in an additional prompt for younger people. We're still debating that. And I think that's actually a national conversation, about how to marry very practical approaches with the national epidemiology to find people, because you can create very complicated algorithms, but they just aren't practical to implement.
And I have one more previously asked question, and then I'll take raised hands to unmute people. So a question asked earlier, I think of your work, Cami, was what percentage of people that you asked agreed to be tested, and of those positives, how many of them were linked to follow-up testing and care with a doctor?
Yeah, that's a great question. We don't have a great mechanism to figure out how many people were asked and declined at that moment, because the prompt stays up. The only way the prompt goes away is if you either test or if you remove the prompt, if you go in and actually inactivate it. And that has essentially not happened unless somebody has documented that they actually came in from another healthcare system with an already existing hepatitis C diagnosis, and so they've already been diagnosed, so they don't need that prompt. And I think part of that is, we've emphasized to them, if you get it in your head that somebody's not at risk and you override that prompt and they end up being the person who had hepatitis C, you've got a real problem on your hands. And just from a medical legal standpoint, that should never be done unless it just shouldn't be done, and it's not happening here. We are currently trying to look at the follow-up. We have a nurse educator who actually mans the hotline, but she also follows up all the antibody-positive tests to make sure that the viral loads are done. And I'm not exactly sure about percent right now. It's over 80% have had the viral loads done so far. And then make sure that they either are being followed by a primary care doctor that we've been working with, because we've also got a telemedicine program we do, or it's on to hepatology or ID. And so but we're still analyzing those data, so I can't give you hard numbers yet.
Okay. Now I'm going to take raised hands. So Jill, you had a question. You should be off mute now. And she may not still be with us. Okay, I have another question online, which is what kind of nutrition is recommended for Hep C patients? We've heard that food can be part of the cure, and are there any recommendations of foods that help the liver?
Yeah, so the first thing I would want to know about before recommending food recommendations for patients is how advanced their liver disease is. Now, one thing is we're almost never doing liver biopsies anymore. I'd say of the last 100 patients we've discussed, for example, in the telemedicine program, about 5 people had unusual situations where we couldn't figure out the right management unless they got a liver biopsy. But for the most part, if you're going out and talking to people, you can reassure them most people do not need a liver biopsy to understand how to manage their liver disease. We've got lots of different ways to figure out who has cirrhosis. If somebody has advanced cirrhosis and the beginning of liver failure, there's certain things that we want them to be doing. One, limiting the use of Tylenol. It's one of our biggest liver toxins that's out there in the, in the sort of usual over-the-counter. People don't even think about it. They don't recognize how toxic it can be. Sometimes people need to limit salt if they've got a buildup of fluid in their bellies, the ascites. But for the most part, what I'm saying to folks is try to avoid, food that you're pulling out of a package. It's high sodium, it tends to have a lot of, processed foods and chemicals and things. Try to eat fresh fruits, fresh vegetables. Get protein. You don't want to be malnourished with hepatitis C, and the vast majority of people don't need to limit their protein. There's no food that cures hepatitis C. There's no food that's particularly sort of liver protective. And so, it's mostly just, trying to get a well-balanced diet with fresh foods that's not overly processed. That's what I recommend.
We have one question, Cami, for your contact info, so I'm going to leave it to you if you want to give out your email or if you'd prefer that people send a message to me first.
Oh, yeah, no, it's if you're going to email me, please CC Tina, because sometimes she's actually the best person to answer the question, or she's got additional resources, or you're asking something really cool and we want to bring you into, I'm going to say, wait a minute, I can learn from you, or maybe, can you share your experience with us? But my email is C as in cat, Graham, Graham, at B as in boy, I as in ice cream, D as in dog, M as in mom, C as in cat, BIDMC, .harvard.edu.
And this is Ryan. I'll make sure that's included when we send out the slides and the link to the archive.
Okay, great.
And if anyone else has a question, please go ahead and submit the question online or raise your hand, and I'll unmute you. Not seeing any additional questions right now.
Okay, well, if there are not questions coming in, we're approaching the hour. And I want to thank Cami and Tina for excellent presentations. And just to reiterate, we will be making these slides available on our website. We'll get them posted within the next 24 hours to the front page of our homepage of our website. So you're welcome to come and have a look. That's nvhr.org. And we will also be providing a link to the archived recording of this webinar and providing Cami's contact information as part of that package, and we'll be sending that out. I believe we can send that out to everybody who registered for the webinar, and we'll send out through our listserv. I also really want to encourage everybody to check out the Baby Boomer Resources page on our website and send us feedback, let us know additional resources you think would be helpful. It's a living page, and we're trying to update it as quickly as possible and have the most recent resources and information about best practices. So definitely please check that out and let us know your feedback. Tina, have any additional questions come in?
It doesn't look like it.
Okay. Well, I want to thank everybody for taking the time to be on the call and the webinar. We will be organizing other webinars on the topics that Tina identified, but if there are specific topics that anybody would feel would be of interest, please do let us know, and we will build that into our schedule. And with that, everybody have a great rest of the day, and we'll talk to you soon.
Thank you, everyone.
Thanks.